Uh, Thank you and good morning, everyone. I'm Rohit Shetty and I've got Simon Clark, my colleague, along with me, and we're going to moderate the session on lumbar degen. We've got 8 papers to go through over the next 1 hour. And the first paper is validity of appropriate use criteria for surgery in degenerative spondylolisthesis, a prospective controlled multi-center study presented by Anne Mannion.
Good morning, ladies and gentlemen. My name is Anne Mannion, and I'm very happy to present this study on behalf of my co-authors, entitled Validity of Appropriate Use Criteria for Surgery in Degenerative Spondylolisthesis, a Prospective Controlled Multi-Center Study. The identification of appropriate candidates for spine surgery is important in order to optimize outcomes and prevent unnecessary risks. And to this end, appropriate use criteria have been developed in order to help clarify the indications for specific procedures. The aim of this study was to evaluate the association between the appropriate use of surgery and patient-rated outcomes in patients with symptomatic lumbar degenerative spondylolisthesis. It was a prospective, controlled, observational, multi-center study with 5 centers in Switzerland and 1 in the USA. We had 737 patients, about 2/3 of them were surgical and 1/3 non-surgical, and the care plan, importantly, was decided by the treating surgeon or physician as per their normal practice. So we didn't intervene, it was simply an observational study. So the first thing to do was to look at their baseline presenting profile to see whether or not that would have made them appropriate for surgery according to the criteria, or whether or not it made them uncertain for surgery, or indeed inappropriate for surgery. And these 3 groups were then compared in terms of the short-term patient-rated outcome as measured using the Core Outcome Measures Index, which had been completed at baseline and at 3 months follow-up. So first, let's have a look at the distribution of the appropriateness ratings. The bars on the left are the patients who got surgery. These on the right didn't get surgery. And as you would expect and hope, the majority of the group that received surgery were considered appropriate, or at least uncertain and equivocal, and maybe a surgical candidate, whereas the opposite was the case for those who did not get surgery. And so we compared the different appropriateness groups, and as is normal in studies of this type, we give the surgeon the benefit of the doubt and consider that those that are uncertain or equivocal can go together with the appropriate as maybe candidates for surgery, to be compared with the group that was considered inappropriate. These are the outcomes in relation to both treatment and appropriateness for surgery, as measured by the Comey score, which goes from 0 to 10, with 10 being the worst value, at baseline and 3 months follow-up. And the first thing to look at is this group that's marked in the dark turquoise, and these are the ones that did the best. That's the ones that were appropriate for surgery and indeed got surgery. And if we compare that with those that were appropriate for surgery, the pale turquoise, but actually didn't receive surgery, you can see that the difference in the score for the reduction in score is 2.9 points. For those that were not appropriate for surgery but nonetheless got it, they also showed a marked improvement from surgery, but not as great as for those who were appropriate. And the worst group of all were those that were inappropriate for surgery and didn't get surgery, so treated conservatively, and these showed very minimal change from baseline. So the difference between those that were appropriate and got surgery was 2.9 points, compared with inappropriate and getting surgery of 1.8. So the criteria help identify those who benefit most from surgery. And we see that too if we look at the proportion of patients achieving the minimal clinically important change score. Those that reach it are in the solid bars, those that don't in the hatched. If you were appropriate and you got surgery, 76% achieved this good outcome. If you were inappropriate but got surgery nonetheless, it was just 61%. And interestingly, those that were appropriate and inappropriate but didn't get surgery, so basically all those that were treated conservatively, only had 26 to 27% probability of having a good outcome. So both appropriateness groups appear to benefit more from surgery than no surgery, but the criteria were able to identify successfully patients who derived greater benefit from surgery. We know that the 3-month outcomes in this group typically predict the 12-month outcomes, but the findings do remain to be confirmed by analyses of the longer-term data. And we would also like to encourage external validation of the criteria before we implement them in practice. Thank you for your attention.
Thank you very much, Annie. Simon, do we have any questions so far, please? Simon, I think you're muted. Can't hear you.
I am. That's my IT skills. Rajat Verma's got an interesting point, which I noted really, that even if they thought the surgery was inappropriate, around 2/3 still got some improvement. So we could maybe ask for a comment from Anne in a bit about that. I think we'll get on with the next paper and we'll collate some of these questions. So the next paper is the impact of adjuvant spinal anesthesia on early outcomes of multi-level lumbar decompression surgery from Mr. Aranganathan. I'll just cue that up now.
Good morning, everyone. I'm Sridhar Aranganathan.
Good morning.
And I would like to share our experience of enhanced recovery in multi-level decompression surgery. This was a project I was involved during my ST8 of training in oswestry. We have no disclosures of potential conflict of interest. Now, in people over 65 years of age, the current literature suggests up to 40% prevalence of lumbar canal stenosis. If non-operative treatment fails, then multi-level decompression has been shown to effectively improve the walking distance. However, these patients present with medical challenges and also malnutrition and borderline depression. A heavy reliance on morphine and deep general anesthetic can give a toll on their recovery, and it becomes an uphill task to discharge them effectively. An alternative is to use the enhanced recovery, and these were the guiding principles of Prof. Khaled's method. These involved giving preemptive analgesia to avoid the response to a physiological response to a painful stimulus. This has been extensively used in multiple elective subspecialties. However, there is limited evidence when it comes to multi-level decompression surgery. So our hypothesis was that if patients are requiring rest morphine, that could improve their mobility and that could lead to early discharge. After obtaining ethical approval, we conducted a 7-year prospective case control study. We included all patients with pure multi-level decompression. Our outcomes was the 48-hour use of morphine equivalent as a primary measure, and these were the secondary outcome measures. We used R statistics for analysis. For the treatment, we used intrathecal bupivacaine, followed by general anesthetic and analgesia and local anesthetic infiltration, and we did not use morphine during the anesthetic period. These were the treatment given for the breakthrough and the postoperative water. For the control group, they had the standard GA with morphine, and they did not have any intrathecal injections. We found during our 7-year period, 82 patients were having the treatment with an average age of 68, with a male preponderance with an ASA level of 2. And we compared them against 226 patients during the same period who had a standard general anesthetic. And we found that the treatment group had reduced requirement of morphine and oxycodone. None of the patients required to stay in HDU, and the pain relief was similar on the recovery and also on day 2. 80% of the patients mobilized within the first 12 hours, and they stayed 1 day less compared to the standard group. Now, if we compare our data with the literature, we used a smaller strength of local anesthetic so that there is early motor recovery. We also have preemptive analgesia, which reduced the nausea, drowsiness, and that led to mobility and early discharge. Our visual analog score for pain is similar to the use of strong anesthetic and is comparable to other data in the literature. The shortcomings of the study was it's a case control study. We only used part of the ERAS protocol, and also there's a multiple factorial influence when it comes to mobility and discharge. So in summary, lumbar decompression is effective with effective pain relief and early mobility and discharge. Thank you very much for your time.
Okay, so we haven't got any questions in from that particular talk yet, but we have had quite a bit of chat with regards to Anne Mannion's talk, the first one. And maybe if I could put some of the questions to Anne. Really, everyone is thinking that the study shows that the best outcomes are achieved, or good outcomes are achieved, whether you think surgery is appropriate or not. What would you comment about that, Anne? If I can let her speak.
Hi there, can you hear me okay?
Yeah, that's good. Technology.
Okay. Yeah, I mean, it's a good point. It's tempting to say, well, just, operate them all, because they certainly seem to do better with surgery than they do in the non-operative group. And I think the point of it is more about, obviously resources are limited, and you actually can't operate them all regardless of baseline symptoms and all these other things. So it's a case of working out how can you best select, and therefore it's perhaps to be seen more in terms of selecting those that are more likely to have a good result. So if the difference is, for example, 76% with a success compared with 61%, then it's a way of being more selective, so that you only choose for surgery those that are likely to do the best from it. The sort of difficult thing is what you do with the rest, because it seems that the non-surgical group really don't do very well at all. I mean, it's a different issue, of course, but I think the way to view the data from this is not necessarily, well, let's just operate them all, but it can be used to be more selective. And of course, they're not perfect. They can be refined, the criteria. We can look at those that were considered inappropriate, but nonetheless did very well, and vice versa, to perhaps see how these criteria might be modified in the fullness of time.
Okay, thank you very much.
Great. Okay. Can I just request all the participants that when obviously we've got 6 more talks to go, is that when you do ask a question, we'll obviously have a lot of questions coming through. If you don't mind putting the name of the presenter at the beginning, because it will help us moderate the questions a bit better. So thank you. Simon, shall we go to the next talk?
I think let's go straight on, and I'll see if we can find a few questions for the second one. We'll be a bit behind. I think that's the way to do it.
Yeah, the next one is from Alexander Breen. Early to moderate disc degeneration does not affect intervertebral motion in asymptomatic controls.
My name is Alex Breen, and today I'm going to be presenting some published work that looks at the relationships between early to moderate lumbar disc degeneration and intersegmental kinematics. Like I say, this is published work, so if you scan that QR code above with your phone, it will take you straight to the open access version of this paper. Interest in studying this rises from the long-standing destabilization restabilization theory of Kirkcaldy-Willis and Farfan in the 1980s. This states that early to moderate disc degeneration destabilizes the motion segments, and late-stage degeneration restabilizes them. This theory persists to this day. To study this, we used a 0.5T Paramed open upright MRI scanner to assess the disc degeneration, and a Siemens Acadis Advantix C-arm fluoroscope, along with bespoke image tracking software to measure the kinematics. We took 10 asymptomatic adults aged 50 to 71 and studied their discs from L2 all the way through to S1 for disc degeneration grade, and looked at the segmental kinematics using the fluoroscopy, both in weight-bearing and recumbent protocols, as the relationships may exist in one orientation that could not be found in the other. This provided us with 40 intervertebral discs for assessment. We graded MRI images using a 16-point grading system from Yaros et al. We also recorded disc height loss and T2 signal loss for each level. The kinematic variables were flexion intervertebral range of motion and translation, laxity, motion sharing inequality, and motion sharing variability. Intervertebral range of motion and translation are traditional measures of spine kinematics. Laxity is an expression of the neutral zone that we can establish from the fluoroscopy. And motion sharing inequality and variability are expressions of how motion is proportioned across the spine during a bend, and have recently been considered as mechanical biomarkers for chronic non-specific low back pain. We calculated the correlation coefficients and p-values for all the variable combinations, both recumbent and weight-bearing. Of all the combinations, only one gave a statistically significant correlation, and this was between intervertebral range of motion and disc height loss. It is noteworthy that of all the measures, intervertebral range of motion and overall MRI grade had a similar correlation coefficient, but did not quite reach significance at the 5% level. Both of these correlations, however, were negative, suggesting that if anything, reduced and not increased intervertebral range of motion accompanies early to moderate disc degeneration. Previous studies have investigated this both in vivo, in patients and healthy controls, and in cadaveric lumbar motion segments, and have found conflicting results. From the present study, it seems clear that in people without low back pain, early to moderate disc degeneration is not related to intervertebral stability. This study has now been published in the European Spine Journal, and if you're interested in the MRI grading system that we used, it can be found within this paper, which is open access. I've put the QR code above just here, so you can open up your phone and scan it with your phone camera, and it will take you straight to the website for the paper, or there is the citation just above it. We'd like to acknowledge the support of the Radiological Research Trust and ASG Superconductors for funding this study, and Professor Francis Williams for access to the unpublished grading system that we used. If you have any questions, I'll be in the forum, or my contact details are just here. Disc degeneration is not related to intervertebral stability. This study has now been published in the Europe. If you're interested in the MRI grading system that we used, it can be found within this paper, which is open access. I've put the QR code above just here, so you can open up your phone and scan it with your... My name is Alex Breen. Today I'm going to be
Great.
We nearly got two for the price of one there. Anyway, again, there's some questions probably coming through for this, but if I could just go back to Ashok's, to Sridhar's presentation before. We've got a couple of questions. One from Ashok is a very good point. Can we get the presenter back up, Mr. Aranganathan, to answer? Hello there.
Hi, I'm just waiting for my video to come in.
Yeah, no, we can see you.
We can see it. That's fine. So it's a couple of questions really. So, had you considered an intraoperative single shot epidural after decompression?
Yes, we considered, but the whole point of this exercise was looking at what we could do to minimize the load of morphine equivalent. I will definitely feed this back to my anesthetic colleagues, and we will come back to you with an answer about it. But that is a fair and valid point, absolutely.
And I suppose the other thing to say is not just epidural, so intrathecal. We've had a lot of success with intrathecal diamorphine with degenerative deformity, so that's something else to bear in mind. Maybe not.
Absolutely.
Okay.
Yes.
All right. Okay. So I think there's no more questions for there. I think we'll get on to the next one, if that's all right.
Thank you.
Sure. Thank you.
Okay. So the next talk is from Mr. El Ghafi, and it's about over-reporting disc herniation by radiologists in lumbar spine MRIs performed with patients with spondylolisthesis. So I'll just cue that up for you.
Morning. Thank you for listening to our study on the race and risk factors for post-operative disc after lumbar decompressive surgery.
In fact, it's not this one.
I'd like to acknowledge my co-authors,
Apologise for that.
imaging providers, and Ms. Fry, who provided 90% of the cases. We have no conflicts of interest.
It's well recognised that lumbar decompressive surgery improves the quality of life as much as any other orthopedic intervention. However, 20 to 30% of patients have persistent or recurrent pain,
with a significant proportion linked to post-operative disc herniation. Our previous study and others identified preoperative ossuary disability score and smoking as independent risk factors for recurrent disc herniation, but the generalization of these results to all decompressive surgery is unknown. The aim of this study was to identify the rate and risk factors for postoperative disc herniation after lumbar decompressive surgery. We prospectively collected clinical data on 1,656 consecutive unique lumbar decompressive patients. The inclusion criteria were lumbar discectomy and or decompression, with or without fusion, and 3 levels or less. Preoperative clinical data was incomplete for 2% of patients. Postoperative data was
Good
collected
morning,
from
everyone.
clinical notes
I'm
and
Sridhar
MRI
Ranganathan,
database,
and I
checked against all imaging providers in the region for missing data to ensure complete data capture. Diagnosis of postoperative disc herniation was by nerve root compression due to disc herniation on MRI radiologist report and confirmed on review of reoperation notes or clinical findings. The Kaplan-Meier method was used to calculate the hazard function for postoperative disc herniation, to compare preoperative disability levels, and for smoking status. Cox regression modeling was used on 14 predictive variables to identify independent risk factors. Univariate analysis showed that the postoperative disc herniation cohort were younger, had higher preoperative disability, were more economically active, and had a higher prevalence of current smokers. Our results show that the highest proportion of postoperative disc herniation cases occurred after discectomy, and the lowest after decompression. As expected, most postoperative disc herniation occurred at the same level as the index operation after discectomy. However, postoperative disc herniation at a different level to the index operation occurred in a high proportion after fusion. Using the Kaplan-Meier method, the 5-year postoperative disc herniation rate was 14%, with over half the cases occurring in the first 2 years. Analysis by surgical category indicates a 1 to 2% herniation rate per year for each surgery category, except in the first 2 years after discectomy. To identify if the ossuary disability index has a dose-dependent relationship, we divided the cohort into 5 even groups of increasing levels of preoperative disability. The Kaplan-Meier method shows that an increased risk of postoperative disc herniation only occurs in patients with an ODI score of 60% and above, and with the increased risk mainly occurring in the first 2 years. Smoking status also demonstrated an increased risk of postoperative disc herniation, also with increased risk mainly occurring in the first 2 years. Cox regression analysis confirmed that the ODI of 60% and above and smoking status were independent risk factors. Rheumatic disorders, employment status, and operation category were also identified as risk factors. Our results are comparable with the literature. Strengths of our study include the largest series to date of prospectively collected data with clinical and reoperation events and near complete radiological data capture. Weaknesses include other potential risk factors not being measured, optimal ODI cut point was not identified, and insufficient events for sub-analysis of each surgical category. In conclusion, we identified the 5-year postoperative disc herniation rate as 14%, and the associated independent risk factors as preoperative ossuary disability index score of 6% and above, current smoker, rheumatic disorders, and work status. Thank you for listening to this talk.
Jonathan Gears. I apologise for that, but it'll keep you on your toes. Rohit, are you around to...
Yes, yeah, so just wanted to apologize to everyone for this breathing issues. Sorry, guys. I think we should go back. I think what might work is probably to just, Simon, if that's okay with you, is to probably take questions after every talk and get the speakers in.
Yes. I'm not sure we have any questions for Jonathan. Although we do have a question from Rajat Verma and another one from Neil Chiverton, so we can come into that.
Sure. Yeah, there's a question from Neil Chiverton that was for Jonathan, saying, what do you think is the underlying relationship between ODI and the risk of disc recurrence? Can we get...
Hello, can you hear me okay?
Yes, yeah.
Thank you. That's an interesting question. We looked into this, and I think it's because the ODI is a non-linear scale, and at 60% plus, you have people with very severe disability. And after the operation, their ODI scores, along with all the other patients, goes down to the same lower level. So there's no difference after operations between the people with high disability preoperatively and those with low preoperative disability. They basically end up with the same low level of disability after the operation, at least in the initial 6 months after the operation. So what things happening is before the operation is that people are very disabled because they've got a very, very high disability. After the operation, they're feeling pretty good. And a lot of patients, because I'm a physiotherapist treating these patients, I've got to explain to them they're actually not that physically fit. They start to get themselves active and moving, and they tend to have a reoccurrence of the problem, I think, in the early first 2 years afterwards, because they're feeling great, but actually physically they're not actually capable of doing their normal daily tasks or sporting tasks, and they can potentially re-herniate because they're just not physically fit enough to do those tasks. We looked into other confounding variables that might explain it. For example, with people with high ODI are more likely to be obese and have depression, but actually these factors are borderline protective factors in reducing the probability of having a postoperative disc herniation. So I think it is mostly to do with the severity of the problem before the operation, leading people to being losing a lot of fitness that they don't necessarily appreciate postoperatively, and don't necessarily take the 6 to 9 months to fully recover from it.
And I suppose the other thing, the follow-up from that was how many of these recurrences needed further surgery out of the, I think it's 14%.
60%, about 60-65% needed resurgery, and that's where we identified, that's the gold standard for identifying it as a postoperative disc herniation. The ones that didn't go to surgery, I had to have the consultant's diagnosis, which had clinical signs and symptoms indicating it, as well as the radiological reports indicating a postoperative disc herniation.
Okay.
Great. Thank you. So we can move on, Simon?
We can.
Yes.
And this would be 0087. This was the one that I was trying to introduce before, which we'll try again, is over-reporting disc herniation by radiologists in lumbar spine MRIs performed with spondylolisthesis.
Great.
So we'll try once more, shall we?
Yes.
Mr. El-Ghafi again.
Yeah, thank you.
El-Ghafi from University of Medical Center. I present our study of reporting disc herniation in lumbar spine MRI performed for patients with spondylolisthesis. Spondylolisthesis is a common cause of low back as well as radicular pain. We'll see a human classification into 5 types, with most common type is L4-5 is degenerative and L5-S1 ethnic. MRI scan is used to assess the degree of spinal canal stenosis in degenerative spondylolisthesis and foraminal stenosis in ethnic spondylolisthesis. X-ray, including flexion extension views, are used to assess the slip grades as well as whether it's stable or unstable. Spondylolisthesis is often misdiagnosed on MRI, as the slip may reduce to normal alignment when the patient lies supine. Disc herniation is often reported at the level of spondylolisthesis. Accurate interpretation of the MRI is of major clinical significance, as it often guides our surgical plan. While disc involved at the spondylolisthesis level often doesn't appear to be normal, healthy disc is not usually a true disc herniation. Instead, it's a pseudodisc. The picture on the right-hand side shows a pseudodisc at L45 spondylolisthesis. You see the blue line is a posterior vertebral line extended along the L5. Majority of the disc material is located anterior to this line, and with the optic illusion, first impression will give that it is a disc herniation, but if you see the majority of the disc lying anterior to the blue line, this is a pseudodisc. The MRI scan here at 4.5 is a true disc herniation, as majority of the disc material extended beyond the posterior vertebral line of L5 compared to a pseudodisc at L5S1. The objective of our study is to determine the incidence of true disc versus pseudodisc herniation at the spondylolisthesis level. The authored hypothesis is that disc herniation has been overreported in setting of spondylolisthesis. This is a retrospective study including 258 patients. The archived radiologist report were grouped as Group 1. A senior musculoskeletal radiologist as well as a senior spine surgeon reviewed the image together, and the reading were referred as Group 2. The two groups were then compared. Majority of patients included in this study were female, average age 59 years. Majority of patients had grade 1 spondylolisthesis, and majority of patients had 1 level spondylolisthesis. In Group 1, a true disc herniation was reported in 42% compared to 9% in Group 2. And a pseudodisc was reported in 58% in Group 1 compared to 91% in Group 2. There was a statistically significant difference in reporting rate between the two groups. The majority of the reporting on the disc at the spondylolisthesis level in the archived Group 1 report was disc bulge. Much of the discussion in the literature was focused on how to describe the disc, whether herniated, ruptured, prolapsed, protruded, bulging, or extruded. However, no literature are discussing the finding of the disc at level of the spondylolisthesis. Pseudodisc is the most common MRI scan finding at the level of spondylolisthesis. The differentiation between true and pseudodisc is important, and the surgical treatment is different. Microdiscectomy versus decompression plus minus instrumentation and fusion in unstable spondylolisthesis. The current study showed over-reporting of disc herniation at the level of spondylolisthesis. Majority of disc pathology at this level are pseudodisc rather than true disc herniation. Accurate diagnosis is vital for planning of surgical intervention. Thank you.
Your screen and it seems to work. So apologies. I hope it's working. Ashok, especially you, I think it wasn't working for you. Any questions about this paper, Simon? Do we have any questions?
I'm going to the chat. There's some people actually. There are some people typing, but there's nothing come through yet.
Okay. Then we move to the next one, and then basically we can, I think probably if you've got some time, because we're just about halfway through, maybe once we finish all the talks, we can get all the speakers and go through all the questions and make sure it's all been answered.
Yeah, good idea.
Yeah, great. Thank you. We're getting there.
Right, Rohit, are you going to introduce the next one?
Yeah, sure. So the next one is 0181, prognostic factors associated with walking ability after surgery for lumbar spinal stenosis. A systematic review by Suzanne McElroy, please. So that is 0181. Make sure we get the right one. And click present. Yes, there you go.
Hello, my name is Suzanne McAvoy. I'm a consultant physiotherapist at King's College Hospital. I'd like to share with you the findings of my systematic review, prognostic factors associated with walking after surgery for lumbar spinal stenosis. Lumbar spinal stenosis is a very common degenerative condition. It causes symptoms of neurogenic claudication, which leads to reduced walking and loss of quality of life. It's the main indication for spinal surgery in older adults. Yet up to 40% of people report ongoing walking disability postoperatively, and those that do report an improvement often do not actually demonstrate an increase in their day-to-day walking. Thus, they're at the risk of negative consequences of inactivity. If we have a better understanding of the factors that influence postoperative walking, we may be able to assist with preoperative expectation setting and inform rehabilitation. Therefore, this systematic review aimed to identify the preoperative factors associated with postoperative walking. 7 electronic databases were searched. All identified citations were imported into RAIN. 2 reviewers independently screened titles, abstracts, and full texts and extracted data. The Quality and Prognosis Studies, or the QUIPS tool, was used to assess the risk of bias for each of the included studies, with each study being rated as low, moderate, or high risk of bias. We included prospective or retrospective observational studies of participants who'd received surgery to treat lumbar spinal stenosis and reported relationships between preoperative factors and postoperative walking. All walking outcome measures were considered for inclusion. The grade method adapted for use in prognostic factor research was used to rate the overall strength and quality of the evidence across the studies. 5,527 titles and abstracts were screened for eligibility. The full text of 322 studies were screened, and 34 studies describing 20 cohorts, including 9,973 participants, were included. This slide shows some key characteristics of the included studies. Due to the heterogeneity in the studies, a meta-analysis was not possible and a narrative synthesis was performed. Only 6 of the included studies was rated as having low risk of bias. 40 different prognostic factors were identified. We grouped these into 4 categories: demographics, clinical, psychosocial, and radiological characteristics. 12 of the factors were mutable, as in they were potentially modifiable. Using the adaptive grade criteria resulted in only 3 factors having moderate quality of evidence. These were: the better preoperative walking was associated with better postoperative walking, and the presence of a spondylolisthesis and severity of stenosis were not associated with postoperative walking. All other factors had low or very low quality of evidence, meaning the confidence in these results are limited and the true effect may be substantially different. In contrast to a previous systematic review, we did not find sex, age, depression, or cardiovascular comorbidity to be prognostic of walking ability. These differences may be due to our methodological changes and differences, including the use of the grade criteria. By applying this stringent approach, the quality of evidence for several prognostic factors were downgraded. Radiological variables were not associated with postoperative walking ability. This is consistent with other degenerative and long-term conditions such as low back pain and osteoarthritis, where correlations between radiological findings, disability and symptoms are mixed, especially in older adults. Thus, factors other than structural changes need to be considered. Only 12 of the factors were mutable. There was low quality of evidence that BMI and smoking were negatively associated with postoperative walking. While these suggest that lifestyle factors are promising targets for rehabilitation, greater understanding of the modifiable prognostic factors are required. In particular, the impact of psychosocial factors, which are known to influence mobility and function in older adults. In conclusion, better preoperative walking is associated with better postoperative walking ability, but there's no association with spondylolisthesis or severity of stenosis. Few studies have investigated mutable psychosocial prognostic factors. Our findings demonstrate a well-designed study to identify mutable prognostic factors for postoperative walking in people with lumbar spinal
stenosis is required. If these are identified and targeted, outcomes of surgery may be optimized. Thank you, and these are my references.
I can't see shall we just run through, Simon, just run through the next 2 because we've got 20 minutes left. which means we run through the next two and then invite all the speakers, and we can just run through the questions. So
that sounds a lot more sensible.
Yeah.
So the next talk we have something that I'm hoping to be educated about. The 0257 is the prognostic indicators of surgical outcome in painful foot drop, a meta-analysis, and it's clearly something that none of us really know the answer. But I'm hoping in 5 minutes we will.
Good morning. My name is Buzzer Said, and I'm a neurosurgery trainee in Leeds. I'm going to present on prognostic indicators of surgical outcome in painful foot drop, a systematic review and meta-analysis of observational studies. Foot drop is a condition we encounter relatively frequently in our units. However, there is no standard management nationally. There is controversy around whether a conservative approach or surgical management is undertaken, and whether surgical intervention is in itself effective. In addition to this, there is no consensus on the timing of surgery, which is demonstrated in a national survey we undertook last year. This formed the basis of our systematic review and meta-analysis. The aim of the investigation was to determine if and when surgical intervention was indicated for painful foot drop. A favourable outcome was defined as an improvement in muscle strength of ankle dorsiflexion. Our primary research resulted in 797 articles being found, and through the process you can see on the left with our Prisma flow diagram, we decreased that to 9 articles, of which 7 were included in the meta-analysis. The inclusion and exclusion criteria you can see is on the right. This overall resulted in 431 patients who underwent surgical decompression for a painful foot drop, with a mean follow-up of up to 2 years. We used the Newcastle Tower scale to assess the quality of non-randomized studies, and all 9 studies were assessed as good quality. The mean age of the sample was 48 years, with a male predominance of 59%. All studies reported on the improvement of foot drop following surgical intervention, and the pooled portion ranged from 67.9% to 96% across them, with the overall mean improvement in outcome of 84.5%. Reports on the rate of recovery varied between immediate to up to 2 years. Only 301 patients among the 7 original studies had extractable data for meta-analysis. Based on available data, we examined correlations between improved foot drop and 4 factors reported in the literature to have an influence on prognosis. This included preoperative muscle strength and duration of paresis, underlying pathology, and age. The first factor we examined was preoperative muscle strength. Operating on patients with moderate weakness, so grade 2 to 3, preoperatively as opposed to severe weakness, grade 0 to 1, was associated with lower odds of an unfavourable outcome when data was combined, or an odds ratio of 0.38. Secondly, we looked at the preoperative duration of weakness. The results showed that operating on patients who have had more than 6 weeks of foot drop weakness was associated with a higher odds of unfavourable outcome on aggregate analysis, odds ratio of 4.95. Moving on, the next factor we compared was herniated pathology versus non-herniated pathology. There were not many studies with extractable data reporting on this, unfortunately. Our results demonstrated operating on patients with disc herniation and foot drop was not associated with a statistically significant reduction in the overall odds of an unfavourable outcome, with an odds ratio of 0.23. And finally, surgery in the younger age group of patients conferred a more favourable outcome than in patients aged more than 50 years old. The limitations of our review and meta-analysis include the following. The studies were relatively small, but this is reflective of the lack of data available. These studies are all observational and come with inherited bias. There were differences in defining foot drop, with some labelling this as a grade of 3 out of 5 or less, and others including 4 out of 5. We excluded patients with mild weakness to eradicate subjectivity. There were considerable differences in the measurement of duration, with some studies reporting on a surgery within 24 to 48 hours, whilst others had compared weeks to months. We also haven't addressed conservative management versus surgery, as there is no recent published literature comparing them both directly. Our findings indicate that age, duration of foot drop weakness, and preoperative MRC grade are strong predictors of surgical outcome. Specifically, earlier surgery less than 6 weeks confers favourable outcome. Patients with moderate weakness, so grade 2 to 3, are likely to have a greater success than those with severe weakness, grade 0 to 1. And younger patients aged less than 50 years have a better outcome. We propose a national prospective observational study for data collection to help standardise treatment of foot drop, which would include conservative management. Thank you for listening.
And if you go to last talk and then take all the questions. So 0328, stitching time saves 9. Comparative analysis of spinal dural tear repair surgery. Get that on now and play that.
Hello, and thank you for joining me. My name is Charles Taylor. I'm a medical student from Southampton University, currently undertaking an integrated surgical master's at Queen Mary's University, London. Today, I'll be presenting the results of a comparative analysis of dural tear repair surgery methods. Before I begin, I'd like to thank my research supervisor and Southampton Neurosurgical Registrar, Mr. Ahmad Khan, who assisted throughout each step of the research process. A dural tear refers to an iatrogenic opening of the dura and underlying arachnoid leading to cerebrospinal fluid leak. They are a common complication of spinal surgery, and particularly of surgery of the lumbar vertebrae. Patients who sustain a dural tear often recover well and do not commonly require further intervention following repair of the defect. However, side effects of poorly managed tears include low-pressure headaches, photophobia, meningitis, and pseudomeningocele formation. The current reported incidence rate of dural tears varies between 1 and 17%, yet despite this common occurrence, definitive guidelines on how best to manage an intraoperative tear are somewhat lacking, and consequently, patient outcomes vary by a case-by-case basis. For this study, data was collected from Southampton General Hospital's online databases, and all patients with the terms dural tear, CSF leak, durotomy, and pseudomeningocele were identified and later included in the study if it could be confirmed that they sustained an intraoperative tear. Patients were grouped and analysed per the repair method they received, and these groups were compared against 5 predefined clinical outcomes, these being the length of hospital stay, the rate of further admissions or revision surgeries, the length of any additional admissions, post-operative infection rate, and dural tear-associated neurological symptoms. Sub-analysis was conducting regarding patient age and BMI. Comparisons between primary and non-primary and artificial and autologous patches were made. Minimally clinically important difference was calculated by the Delphi procedure amongst resident neurosurgeons to enable a formal consensus to be developed. This retrospective study identified 106 patients who sustained an intraoperative tear in Southampton University's General Hospital between the 1st of January 2016 and the 4th of November 2019. Primary closure, a sealant, and a drain was the most common repair method used, and primary closure was present in 56% of all cases. However, combinations of sealants, patches, and drains without any form of primary closure were also commonly opted for. Following a multivariate analysis of variance, no significant difference was observed between all repair methods. However, when comparing primary closure with or without a patch against all other methods of repair, primary closure with or without a patch scored better in 4 out of 5 clinical outcomes. Length of hospital stay was on average 3.5 days shorter. The rate of additional admissions or additional surgeries was halved, and the length of additional stays was on average 1.35 days less. However, for this outcome, no minimally clinically important difference was observed. Interestingly as well, infection rate post-operatively was reduced to 0. The incidence rate of dural tears was 5.81% in this study, and of the 106 tears, 46 were caused during operations of the L4, L5 spinal level, and 73% were sustained between L3 and S1. With regards to patient age and BMI, the average age of patients in this study was 55, and MANOVA analysis indicated that age had a significant impact on the post-operative outcomes, with all measures indicating worse outcomes with increasing age. With regards to BMI, statistical significance was not achieved. However, readmissions and rate of revision surgeries were greatest in the moderately obese and severely obese categories, and infections were only present in the overweight, moderately obese and severely obese patient population. Finally, when comparing artificial against autologous patches in conjunction with primary closure, the artificial patches scored better in 4 out of 5 of the clinical outcomes again. Length of stay was on average 1.5 days shorter. Rate of additional admissions showed a 100% reduction and a 67% MCID improvement, and length of additional stays was on average 5 days less. Severity of neurological symptoms also displayed a 0.67 mean score reduction. So, to conclude, this retrospective comparative study demonstrates that primary closure with a sealant and a drain was the most commonly opted for method of repair. However, despite primary closure being generally considered the gold standard, it was only used in 55.7% of cases. With regards to the 5 predefined clinical outcomes, age of patient had a significant impact, and rate of readmissions, revision surgeries, and infection rate increased with BMI. Primary closure with or without a patch was shown to be superior in 4 out of 5 of the clinic outcomes, and as were artificial patches. This study highlights the importance of age and BMI on post-operative jaw tear outcomes and supports the use of primary closure with or without a patch. This study also provides limited evidence in favour of artificial over autologous patches and recommends that jaw patches always be used in conjunction with primary closure. Thank you for listening, and I welcome any questions you may have.
Great. Thank you, Charles. Can I get someone from admin to invite all the speakers, please? Because we can run through the questions. We've got 10 minutes left, so I think we're good for time. Can someone get the speakers on, please? Great, thank you. Simon, shall we just go through some of the questions?
Yeah, I think obviously not for now. It'd be lovely if the admin people could stratify the questions by presenter, because we've got about 1,000 questions all jumbled up because everyone's thought with their kind of stream of consciousness. But let's go back and see what we can find. I think, Anne, we went through yours at the time, didn't we?
I think there's one actually that I didn't answer, Tim German's question. I just noticed it came up now. I don't know whether he still wants me to answer that.
Yeah, go for it.
Does this not reflect the fact that the subtleties of making a diagnosis and then making a decision about whether to proceed or not cannot be replaced by an algorithm? That's what the question was. So to answer that, first of all, in terms of the subtleties of making a diagnosis, this wasn't attempting in any way to help with or to make the diagnosis. These were patients where the clinician had decided that the patient did have lumbar degenerative spondylolisthesis. So it's more a case of using the algorithm to say whether or not they were likely to be appropriate for surgery once they had that diagnosis. So just to clarify that, first of all. And then secondly, it's important to look at what we mean by appropriate. It doesn't necessarily mean that you should or shouldn't do it per se. It's just that when you consider something to be appropriate in this terminology, it's that the expected health benefits exceed any potential risks by a sufficiently wide margin that the procedure is worth going ahead with. So the thing to consider is that, yes, although a high proportion did do well for surgery that were maybe considered inappropriate, what we didn't do was look at what the corresponding risk is that they're undertaking in deciding to go ahead with it. So the whole thing is kind of a balance between the expected gain, which is one side of the story, and then the associated risk. And then finally, I would say that it's kind of used in guidance. It's not supposed to replace, obviously, the clinician in any way. And so I wouldn't consider it useless. It's just that it's meant as an aid to decision-making by using the evidence that's been developed on the basis of the algorithm's initial development in the first place.
Okay.
So I hope that
answers the
question.
Thanks very much. Thanks very much. So I've written a few things down as we've gone along. I've got a few things. So a couple of questions for Mr. El Ghafi from Rajat Verma and Martin Wilby. It kind of overlaps a little bit, really, and they're just wondering, with a disc protrusion with a slip, is that suitable for microdiscectomy? And do you advocate fusions in these patients, or discectomies in true discs and not in the spondy groups? And really, therefore, the question would be: does a herniation in a spondylolisthesis therefore reflect ongoing instability? I wonder if Mr. El Ghafi has a comment for that.
Yes. In general, we do fusion in spondylolisthesis with disc herniation because we feel that the part of the problem is instability, especially if you see in their MRI there is fusion in the facet joint, fluid in the facet joint, or if they have isthmic spondylolisthesis. However, if we have an old patient like 70 or 80 plus with true disc herniation and not much back pain and just radicular pain, there is a case that you just do microdiscectomy in this particular case. But in general, when we see spondylolisthesis, we tend to fuse them because we worry about instability.
Okay. Rohit, have you got some questions you want to collate here? There's loads of...
Yeah.
I've got another. Rajat Verma. He's
next one
very
is
active on the chat today.
Charles from the study.
Hi, yes, I'm here, but I'm not sure. Can you hear me?
Yes. So there's
yes.
Wonderful. Yeah. So I see a question from David Bell there regarding the location of the tears. Unfortunately, we were unable to determine. Sorry, pardon.
There's a couple of questions.
Yes, please.
Yeah. There's one from David asking about midline. Yeah.
Charles,
so yeah, with regards to your question, David, we were unable to determine the location of the tear.
Why do you answer David Bell's midline versus lateral recess?
Can you hear me? Okay. Can you hear me? Okay.
Okay. Yes.
Sorry, I think there's a bit of a delay with my microphone. Yeah. So with regards to David, your question, we were unable to determine the location of the tear due to the retrospective nature of the study. The data we collected was limited to that based on the clinician's notes and the operative notes, and rarely was the location of the tear actually documented in their notes, so we were unable to analyze that. With regards to Stephen, your question, I looked in the differences between groups were not significant. Compared the groups with MANOVA, a multivariate analysis of variance, there was no significant results. However, then sub-analysis looking at primary closure with or without a patch compared to the other forms did give back significant results. There we had significant differences in favour of primary closure with or without an artificial or autologous patches. But when comparing the groups individually to each other, no significant difference was observed. One more question, was a microscope used for all the patients for the surgery and for the primary repair? Was micro repair instruments readily available? And that was again data that we were unable to collect due to the retrospective nature of the study.
Okay.
There's a question from Charles Davis about foot drop. The question is whether advancing foot drop should be an emergency. Is Fozia online?
Hi, can you hear me?
Yes.
Thank you for the opportunity to present. The way we look at it in our centre is if there is a presentation of an acute foot drop, it should be referred to the acute person on call, because we do see it as an acute presentation. Rather than being referred through outpatient clinics, and that's something that we'd want to propose. Yes. That we'd want to show in a national study. Really, that's the method that we'd like to take forward.
Okay. Well, we're quickly running out of time. I think I'd just like to take the opportunity to thank all the speakers in these kind of slightly difficult online environment today. I think everyone's had some very interesting talks this morning. Thanks again.
Thank you.
Thank you, guys.